Welcome to AETCM, the Emergency Medicine Channel. Shall we start? 6-year-old female child came to our ER with history of fever, maculopapular rashes since 5 days. Initial 10-second assessment by pediatric assessment triangle. Its appearance-wise, child is active, alert, tone appeared normal, interacting normally. Work of breathing, normal breathing. There is no use of accessory muscles of respiration. Circulation part, skin appeared pink in color.
What will you look in the B part triangle?
B for work of breathing.
So A is for?
Appearance.
Appearance. B is for?
Breathing bar.
Breathing. What all things will you check other than breathing in B?
Use of accessory muscles of respiration, respiratory distress, intercostal indrawing.
Any nasal flaring from the nose, nasal flaring, any use of neck muscles, and any intercostal retraction and subcostal recession. Okay. Then you will have to look for the tone. You can remember it as tickles. You should look for tone, interact, color, tone, interact, color, look, and gaze or speech of the child. Tone, interact, color, look, and speech. Speech includes sounds also. So that much things you need to look in breathing. Circulation? Circulation,
look for color of the skin is pale, cyanosis, pink, normal. Also the oral
or mottled appearance. Mottled appearance will be seen in severe dehydration. Okay.
And primary survey, airway was patent. There is no added sound, no stride or gurgling. Breathing part, respiratory rate is 26 per minute. Saturation 100% room air, ironary bilaterally equal, no added sound. Circulation part, BP is 86 per 60 millimeter mercury, heart rate is 116 per minute, and CRT less than 2 seconds. In disability part, GCS is full, pupils are bilaterally equal. Exposure part, temperature is 101 degree Fahrenheit, GRBS is 80. The weight of the baby is 24 kg.
Okay. In children, no need to check GRBS if the child is active. Okay. Because that itself can irritate the child. Okay. So, this point, what will you do? So, primary survey, there is tachycardia. BP, everything is normal. Only thing is tachycardia is there, fever is there. So, and patient came with fever with rash.
Rashes.
So, what is the first step you need to do?
First of all, antipyretic.
Before that?
Face mask.
Face mask? Patient is maintaining saturation. First, isolate this child.
Isolate the child.
Because the child came with a fever with rash, so it might be contagious. So, isolate the child, put the child in isolation area, and we will also have to wear our personal protective equipments. Okay. Then we can give the antipyretics. Okay.
According to weight, 10 mg per kg is the paracetamol dose. So we give 250 mg PCM given.
So what is the age of the child?
6 years.
6 years. So how will you give 250 mg paracetamol?
IV.
IV?
Suppose 6 years.
6 years is there. So how is paracetamol syrup available?
250 ml for 5 ml. In 5 ml, 250 ml.
5 ml contains 250 mg. So 250 mg is the required dose that can be given. So 5 ml of paracetamol can be given. In case of infant, it is available as 125/5. So that also can be given. Or if at all if the child is not able to take orally, you can give it as suppository. How is suppository available?
80 mg, 120.
80 or 160 or 170 mg, that is available. Okay. So, better not to prick the child. You can, if the patient is able to tolerate orally, give it syrup orally. Okay.
The exposure part, there is maculopapular vesicular rashes over the face, trunk, and both upper limb. Is the, in secondary assessment, sample history, signs and symptoms. Child have intermittent high-grade fever associated with generous tiredness since 5 days. After 3 days, her mother noticed some skin lesions over the trunk area. There is no history of any travel, no history of any contact with pets or animal, no history of vomiting or loose stool. And she was studying in a preschool, and from her history, she has a contact with varicella positive preschool.
Okay.
There is no allergic history. There is no history of any medications. Past history, full-time baby with first child of non-consanguineous marriage. Immunization history, immunized as initial dose of 12th month, and second dose was not taken, and developmentally normal child.
So varicella zoster injection was taken
at 12th month.
Ideally, it should be taken after 12 months. Ideally, in the 15th month. After 1 year only, it should be taken. So, first dose was, when will you take the first and second dose?
Initial dose is 12 to 15 months, first dose is taken. Then 4 to 6 years, second
dose should be taken. So, either 3 to 4 year gap should be there between the two vaccines. So, what do you think regarding this history?
Fever with maculopapular rash, and also she has a history of contact with varicella infected children, so there is a chance for varicella infection.
So usually varicella starts with fever, malaise, sometimes there can be runny nose, upper respiratory tract infection features, pharyngitis, these features can be there. After that they will start developing rash. Where will the rash start?
Initially appears on the trunk area, then it goes into face and upper limbs.
So what is that pattern called?
Centrifugal distribution from center to periphery.
Okay, from center to periphery it is going. Okay. What are the other differential diagnoses which you need to consider?
Fever with rash, with maculopapular rash, we can examine them as fever classified as first day disease. It is measles, and second day disease it scarlet fever, and third day disease.
Measles is caused by?
Measles paramyxovirus. Measles virus.
So how is the pattern of rash in measles?
Pattern of rashes. Initially rashes start from behind the ear, then it goes to face, trunk, and all extremities.
And before the rash, what will come?
There are coplic spots in oral mucosa.
Okay.
Then scarlet fever, it is caused by Streptococcus pyogenes. Third disease rubella, caused by rubella virus. Fourth disease is
so scarlet fever, there can be the strawberry tongue, cervical lymphadenitis, these things can, and rashes will be there. So sandpaper rashes will be there. Third disease?
Third disease rubella. Rubella is German measles. Rubella features four shimmer spots on oral mucosa. And fourth disease is Duke's disease. Then fifth disease is erythema infectiosum caused by parvovirus B19. It is also on slap cheek appearance.
So child will be such fifth disease, child will be active mostly, but the cheek will appear very red. Okay.
Sixth disease is roseola infantum. These are the exsanguineous fever, and DDs of maculopapular rashes in viral we can see is measles, rubella, varicella, and bacteria it is scarlet fever, erythema marginatum rheumatic fever, leptospirosis, and in parasite in disease rickettsia causes scrub typhus, and others are Kawasaki disease and drug induced.
Okay. So what will be the type of rashes in chickenpox?
Maculopapular rashes with vesicular lesions and pustules.
More like clear vesicular lesions. Okay.
Duodenal appearances.
Okay, okay. And how did you proceed?
Then general examination active and alert. There is no any focal neural deficit system wise within normal limits. Initially we control the antipyretic measures given, and child is 6 years, we can give syrup aciclovir According to weight, the dose is 80 mg per kg per day in divided doses every 6 hours for 5 days. So Acyclovir is available as 400 ml per 5 ml.
What are the indications of Acyclovir? Usually in all chickenpox is antiviral necessary.
No, not
When all will you give?
Any high grade fever, not.
If the child is having multiple contacts and all, and if many are affected and if many are having severe disease, then we can consider giving. Then otherwise, if the child is having any non-skin issues, like any skin, that means the skin barrier will be affected. Already if the child is having some skin diseases, or already if the child is having some chronic pulmonary diseases, then only we'll have to consider, because one of the complication of varicella is pneumonia. So if the child is having already a skin infection or any pulmonary diseases, then we can consider giving. Then in some cases, like patients, child who has previously had Kawasaki's disease might be taking aspirin, salicylates and all. Such scenarios we will have to consider giving. Otherwise, mostly management is supportive only. We can treat the fever, you can treat the symptoms, and we can treat the blisters, skin itching and all can be treated with any antihistamines or like that. So only if the child is having some other issue, only we will be consider giving Acyclovir. So Acyclovir doses
80 milligram per kilogram per day is the children's dose. That is given is 6 divided dose.
So totally one day, how much doses the child has to take?
This child's weight is 24 kg. So after calculating is 320 milligram for each dose. So Acyclovir is available as 400 ml per 5 ml. So 4 ml QID for 5 days.
What is the other drug available?
Valcyclovir is available.
What is the difference between Acyclovir and Valcyclovir based on dose? Dose is same only, right?
But the decrease the duration of
duration is
time,
frequency is less for Valcyclovir.
Easily take the.
So Acyclovir usually 18 to 20 mg per kg, and we'll have to give 5 times a day Acyclovir for minimum of 5 days. And if the rashes are prolonging, we can extend it. Whereas Valcyclovir same dose 18 to 20 mg per kg, but only TID dose is necessary, and that also can be given to 5 or more days. Okay.
Then we can take post-exposure vaccination can be available.
When all will you consider giving post-exposure vaccination?
In immunocompromised individual and in pregnant women's post-exposure prophylaxis.
Pregnant woman, ideally we are not supposed to give the varicella vaccine. If at all a woman is getting a varicella vaccine, she is not supposed to be pregnant within the next 3 months. Okay. If a lady is pregnant, only after childbirth she is supposed to get the varicella vaccine. So when all will you consider? Otherwise, suppose this child's parents, everybody already had chickenpox previously, will you consider giving? Already this child's parents, everybody had chickenpox previously. Is it necessary to give vaccine? What do you think? Will you give vaccine? It is not required because it will chickenpox come again?
Chickenpox not come again.
That means varicella zoster is very unlikely to recur again. So after many years, sometimes some of these virus might be dormant in the body and it might come as a herpes zoster infection. But if the patient already, of the bystanders already had chickenpox previously, they might be mostly immune. So we don't have to unnecessarily vaccinate them. Suppose the parents, or if the child is having some siblings, they who have never had chickenpox, then when will you give vaccine?
Within 3 days of exposure, we give vaccine.
Ideally up to 5 days. Within 5 days, we should give vaccine. Okay. And before giving vaccine, should we test something? Suppose a bystander is having a doubt whether this bystander had chickenpox previously or not, not very sure. In that scenario, you can send for a immune status, immunoglobulin. You can check for the antibody titer of that bystander, and then if the titer is low, then you can give vaccine. And vaccine should be ideally given within 5 days. Okay.
Along with the vaccine, immunoglobulin also needed.
Immunoglobulin, I will tell you about that. So vaccine we have mentioned. So suppose another bystander comes who has never had chickenpox, took vaccination 2 years back, and now has contact with chickenpox. Does that bystander require vaccine?
He had a history of chickenpox?
No history of chickenpox. Vaccination history is there.
Okay. Initially check for the antibody titer if it is.
You can check the antibody titer like that, but if at all they are asking for a repeat vaccine, you don't have to give vaccine. As I told before, as in children we give in first 15 months, then we will repeat after 4 to 6 years. That means we are giving at least 3 to 4 years gap. So ideally we can give a 4-year gap. So if someone has got vaccine 2 years back, we can wait 2 more years. No problem. So when all will you give immunoglobulin?
In immunoglobulin also there is a primary exposure given within 96 hours along with the vaccine.
Immunoglobulin is usually given in case of in a scenario whether like very immunocompromised people, malignancy, such cases only we will be considering giving immunoglobulin. But otherwise immunoglobulin is usually given in case of pregnancy. So in pregnancy we are not able to give vaccine. In pregnancy we are not supposed to give, and if you are planning to become pregnant in the next 3 months also, we can't give vaccine. In such scenarios we can give immunoglobulin. Okay, so within 10 days you can give immunoglobulin, and suppose this individual gets exposed to chickenpox again, when can we repeat the immunoglobulin? Suppose one pregnant lady got exposed to chickenpox, and after some days, if the pregnant lady again get exposed to chickenpox, you can repeat only if the first dose was given more than 3 weeks. So first dose can be given, and after 3 weeks only you can repeat the immunoglobulin. Okay.
Dose is 125 international unit per 10 kg of body weight.
Okay.
Maximum dose is 625 international unit. Minimum dose is 125 international unit.
Okay. Anything else? Okay. Since we have discussed about pregnancy, we will talk some more about the pregnancy related issues. So, pregnancy we are not supposed to give vaccine, only immunoglobulin will be given, and if at all required, we will repeat after 3 weeks. Okay. Suppose a pregnant lady comes with chickenpox. How will you manage? Usually pregnancy with chickenpox might have a grave effect on the child. Okay. So in the first trimester, especially if the pregnant lady is less than 28 weeks pregnant, there is a chance that the child will get affected, but only in around 2% of the children might get affected. So chances are less, but still we will have to prognosticate regarding that pregnancy, and this pregnant lady should be monitored in the coming months based on ultrasound scanning for fetal monitoring. Like there can be problem with the eyes, there can be eye deformity like cataract and all.
Limb defects, microcephaly, limb defects.
Microcephaly can be there, then any limb deformities can be there, any bladder dysfunction can be there. It is rare only, but we will have to follow up that lady. And how will you treat? Same as already we can't give vaccine now because already pregnant lady is having chickenpox. So in that individual you can give acyclovir with added risk. Acyclovir in pregnancy is not that recommended. There are risks. So by telling the risk you can give acyclovir for the pregnant lady. Okay. And if she comes, if the pregnant lady is coming, and when all will you consider admitting a pregnant lady with chickenpox?
Any complication, like pneumonia?
Pneumonia. Any pneumonia then other complications like encephalitis, like altered sensorium, fever, severe headache, encephalitis, then hepatitis. So if we are suspecting encephalitis, pneumonia or hepatitis only, then only we need to consider admitting the pregnant lady. And usually this complication will only come if the pregnant lady is already having some lung disorders like any emphysematis or any chronic smoker. Or already the pregnant lady has some issues, only there is a chance of such complications. Okay. Suppose a pregnant lady is coming from 28 days to 36 weeks, 28 weeks to 36 weeks. How can you prognosticate that pregnant lady?
After 28 weeks, the infant less chance to get, because already there is a full development is done in initial first trimester. So less complication to.
It is very unlikely that the child might get affected. And another thing is that if at all this pregnant lady, if at all the child is being born, the child might be immune to chickenpox. So the child might get shingles after many years, but the child might not get chickenpox in their life. Okay. And the complications are also less, and it is somewhat safer to give acyclovir also for that pregnant lady. Okay. Then next is from 36 weeks to birth. Neonatal time. So 36 weeks to birth, if at all the pregnant lady is getting chickenpox, then if she delivers, sometimes the child might be born with chickenpox. Okay. But the child might be somewhat immune because it's coming from the mother, but child might be born. And after birth, if the child is getting exposed to chickenpox, and if the mother was already immune, like after birth the child is getting exposed and the child develops the rashes like that, and if the mother was immune already, sometimes the child might get saved. The child might not get affected. But if the child, if he is not getting any passive immunity from the mother, then the child needs to be monitored for the next 28 days. But the child can be given breastfeeding and rest of the things can be given. So after birth, till 28 days, the child should be closely monitored if the mother is not immune. Okay. Anything else? Okay.